Generally, you will have a pre-operative patient who could be there for a workup or for optimization. That could be one kind of a situation. The other could be a post-operative patient who is either undergone an elective surgery or an emergency surgery, and the patient is in the ward in front of you, and the scenario poses a certain situation and you need to address that situation. And these patients are critical patients, so some vitals will be given by the examiner at the station, and patients will have various tubes attached to their body. There will be oxygen, there could be oxygen mask if the patient is very sick. Patient could have a Ryle's tube, patient could have abdominal drain, patient could have a central line, and there will be questions centered around pain relief, sepsis, and what to do with the tubes that are there in the body, etc. So generally the way the ward round is made out is that the examiners sit at the various stations. That stations are the patients who are the post-operative patients, and you as candidates are moving from one station to the other. So the examiner has got a written brief about that patient, and I will be taking you through the situation like that, just as it happens in the exam, and then we will discuss what is asked and what is expected of you for that particular situation. So let's start with this first case, and this case is of a case of post-operative case of a cholecystectomy has been done, laparoscopic. The patient is a 35-year-old lady. It's the first post-op day. And the examiner is telling you that the patient has reported uneasiness and discomfort and vomiting on the first post-op day. And the added information that is given to you is that it was a difficult cholecystectomy. However, it was completed satisfactorily as per the notes, and the patient and the surgeon decided to put in a drain. And you are the resident on duty who has come to assess the patient on this morning. So how will you proceed, doctor? This is how the question poses to you. So now you have to start thinking, what will you do? So this is not a station where you will start going and examining the patient. You are not supposed to examine. You are supposed to tell what you will do, because this is a structured exam for 5 minutes. After 5 minutes, the bell will go and you will be off to the next station. So you have to tell, I will look at what. So let us see. What are the things that you are going to do? You are going to look at the vitals. So vitals are very important. The first and foremost thing that you are going to do is to look at the patient's pulse and the patient's blood pressure. Very importantly, you will also see whether the patient has had a urine output monitored or not. So these are the initial things that are going to be said by you, expected by you. And pulse, which is more than 90 and definitely more than 100, shows that the patient is having some kind of a condition. Either it could be because of post-operative pain, or there could be some abnormality inside the abdomen, and we are worried about two things after laparoscopic cholecystectomy. You will say that I'm worried about bleeding having undertaken, or there could be a collection. You are working around the cystic duct, around the common bile duct. The brief already tells you that this was a difficult cholecystectomy, and once this is a difficult cholecystectomy, you need to be concerned about the fact that the biliary system is at risk. So that's our area, and supposedly the cholecystectomy should have been done here, and if it is a difficult gallbladder, then there could be a situation of lot of adhesion at the liver, so there could be post-operative, there could be bleeding and collection of blood. And of course, you have tied important vessel here, which is also clipped. That is the cystic artery. And if the surgeon was not very clear, there could be damage to the vascular structures, and God forbid, if something else has happened, then there could be problem in the common hepatic duct or in the common bile duct as well. So there could be a problem in the flow of bile, which is going downwards. So the first thing that is going to happen is the pulse is going to shoot up. If the sepsis has happened, now sepsis takes 24 to 48 hours. So you don't expect sepsis to set in just 12 hours or 24 hours after the surgery, even if there is a bile leak. So the blood pressure may not be down, but the pulse is the first indicator. That is very, very important. Urine output is an important indicator, because whenever there is a situation of a loss, there will be loss of the peripheral volume. There will be something like a subclinical shock. The urine output will go down. Now remember, there is also a physiological decrease in the urine output because of the antidiuretic hormone that comes into play after any surgery. So if the volume replacement is not equal, then there may be a normal physiological decrease in urine output, which we have to differentiate from the decrease in urine output because of a volume loss. That's important. So for this, the intake output chart has to be seen. So you will say, I will look at the intake output chart, and after having seen the vitals, I will look at the patient. I will see what is the coherence level. Is the patient short of breath? Look whether the patient appears hypoxic or not. Look at the oxygen saturation, which will be there on the probe. Look at the monitor. If it is not there, I would like to connect and see if the patient is hypoxic, because chest conditions can happen if the patient is of that particular age group and has got a pre-existing condition. And then after having done that, I would like to assess the abdomen. So doctor, what would you like to see in the abdomen? I would like to see for any whether abdomen is soft or whether there is any guarding, rigidity or signs of peritonism. So signs of peritonism is something that will be, so peritonism, that means any rebound coming in the abdomen will be a problem. Now some amount of tenderness will be there because there are ports, so there will be some tenderness. So you need to be very careful when you look for rebound, but rebound is kind of a generalized phenomena. Any patient who has had a lap cholecystectomy normally has a soft abdomen. There is no reason for them to have any generalized guarding rigidity. So you should look for signs of peritonism, and if they are there, then this is a sign of acute collection or some reaction in the overlying peritoneum. And then what would you like to see? The drain. So the examiner has given you the cue that there is a drain. So you would like to see what would you like to see? You would like to see the color of the drain output. You would like to see the quantity. And the examiner just wants you to know if it is very bright red colored blood coming. That's not expected after 12 hours. That should have become light serosanguinous, or it should have had a differentiation between it should have become serous because there is no active bleeding. But if it is bright red, then even if it is a small quantity, it is not correct. There is a sign of some bleeding or some suspicion of a blood loss going on in the abdomen. And obviously this is happening because you have noticed that the pulse is, let us say, 120. So you are looking for causes. Either it is because of some pain, which is this 120 is out of proportion. You should not get pain in lap cholecystectomy and cause 120 tachycardia. So you have to look for some other cause. One is bleeding, the other is some bile collection.